Good day, my name is Martínez, and I am a third-year resident of Internal Medicine and Hospital Federal in Mexico City. Today, I'm talking about a case report of granulomatous peritonitis secondary to a foreign body after an emergency surgery. Peritonitis is an inflammation of the serous membrane that lines the abdominal cavity. The granulomatous type is reported caused by infection, as with Mycobacterium tuberculosis and Ascaris lumbricoides, malignant or idiopathic entities. In fact, this is a very rare complication in the postoperative context of an emergency surgery. One of the treatment theories is contamination of the cavity by foreign bodies talked from surgical gloves, foreign particles, or by the colon contained in surgical disposables. Potential complications include the formation of adhesions with intestinal obstruction or fistula. The pathophysiological mechanism consists in a delayed hypersensitivity response mediated by cellular mechanism with the formation of granulomas and causing a broad spectrum of clinical presentation. The following is a clinical case of granulomatous peritonitis associated with a plant-type foreign body in a postoperative patient for emergency surgery due to intestinal perforation. A 59-year-old woman with a clinical history of hypothyroidism under substitution treatment, appendicectomy in childhood, and diverticular disease presented with a clinical picture of abdominal sepsis and septic shock. An exploratory laparotomy was performed with sigmoidectomy, Hartmann procedure, colostomy with lavage, and cavity drainage. She was maintaining antimicrobial therapy with carbapenem, oxazolidine, and echinocandin. Subsequent microbiological isolation were performed and Pseudomonas aeruginosa, Enterococcus fecalis, and Escherichia coli was shown. However, during the postoperative, she remained with diffuse, moderate to mild colicky abdominal pain, with mild nausea and not correlated with oral intake. At day 17 postoperative, she presented with 26,000 leukocytes and persistent fever up to 38 Celsius degrees, continuing with the pain described without peritonitis. Concomitant infections and other causes of leukocytosis were allowed, such as thyroid overt replacement. It was decided to perform exploratory laparotomy in search of etiology. Release of intestinal adhesions, lavage and drainage of the cavity plus partial lumpectomy were performed. Samples were taken and histopathology concluded granulomatous peritonitis due to a foreign body plant type and acute peritonitis. Steroid management was started. Conclusion: this entity should be considered as a differential diagnosis in those patients without an obvious point of infectious origin after a surgical invasion, mainly in those practiced urgently. Thank you.